Everybody, good morning, good morning, good morning. We're about to start. Please, can you take your seat? Great. Wow, what can I say? Good morning and welcome to our ViiV-sponsored symposium. Today, our symposium for ViiV Healthcare is titled, I Am Not a Statistic, Hear Me, Voices of Young People Living with HIV. And I am so proud, so proud of why we have this topic being discussed today. So let me start by introducing myself. I'm Sibulele. I am the Regional Medical Lead for ViiV in Africa. And I am absolutely blessed to have the panel that we have today. But before we introduce the panel, I'd like to give you a little bit of a background on why this topic and this important symposium is needed to be heard today. One very important man once said, a good doctor treats the disease, a great doctor treats the person. I will leave it up to you to keep guessing who said that. So as ViiV Healthcare, we're a company that really takes the lead when it comes to research and innovation and making sure that we bring medication that improve the quality of lives of people. But with that said, at ViiV Healthcare, the voices of the people living with HIV, the voices of the community, they are absolutely important in everything we do. So this symposium here is really to say, this shouldn't be about ViiV only. The voices of the community, the voices of the people who use the medication should be for everybody. So why is it that we're in a situation where we need to listen to the youth? The slide is not working well, so I am going to improvise. So we've got a situation here where policymakers, decision makers, and all who are involved in the rollout of HIV management and the care thereof sit and they discuss and they make sure that whatever system they've put in place is a system that caters for all. But my question to you is, when you put these in place, has anyone engaged with the youth? Has anyone actually listened to what the youth need? Has anyone questioned whether the systems in place cater for the needs of the youth? If we are going to be great clinicians, if we're going to be great scientists, if we're going to be great healthcare providers, we need to make sure that the young people living with HIV are partners when it comes to really looking at holistic management of HIV, people living with HIV, but also of the young people who have a reason to needing HIV prevention. This slide just highlights adolescent girls and young women. Very key. We always need to focus on adolescent girls and young women because the burden of the disease is so key for them. But having said that, for this slide, why have we left key population behind? When we look at the slide, we realize that we've got the transgender population, key population, and we've also got the gay population, key population. But it's a young population that has been left behind, and sadly for me, in Africa, it is hugely left behind when we're really looking at the voices of the people that we need to listen to if we're going to make sure that we win come 2030. So that was my introduction, and I am super excited to welcome our panel. I have got Dr. Nneka Nwokolo. Dr. Nneka Nwokolo is head of our patient engagement at ViiV, and she's also a physician working in London. And then I have our beautiful sunflower, Sunflower is from Zimbabwe, and she represents the Young People's Network. And then we've got Dr. Lauren Jenny. Dr. Lauren Jenny is a research clinician working at the Desmond Tutu Foundation, focusing on therapeutics. Great. And then I've got Sibu. Sibu is Duke Fellow activist and global speaker. And one thing that I'd really like, before I hand over to our next speaker, this is a discussion, and I'd really like to emphasize that. Whilst we have a panel here, this is a discussion for everybody in the room. Challenge, ask questions, bring about solutions, comment. We really want to make sure that this is as engaging as possible. So let me hand over first to Dr. Nneka Nwokolo.
Thank you very much, Sibu. And good morning, everybody. And I think, as Sibongile said, we really want this to be a discussion, and we've got plenty of time at the end for questions and answers, and for you to please contribute to this. So thank you very much for being with us today to discuss young people's experiences of healthcare and their thoughts on how to help it meet their needs. But before we do that, I'd like to say a little bit about where the idea for this symposium came from. Last year, some colleagues and I held an advisory board in Cape Town and invited an incredible group of sex and gender diverse young people from South Africa, Malawi, Botswana, Kenya, and Zimbabwe to share with us their experiences of living with HIV, their hopes for the future, and how they believed that healthcare should be delivered. And I am not exaggerating when I say that it was one of the best community engagements that I have ever participated in. And the session resonated with me for two particular reasons. Firstly, the powerful way that Sunflower, who you've just been introduced to, spoke of her experiences, and we're really grateful that she's here today to share those experiences again with you and her thoughts about healthcare and how it should be delivered. But also because it reminded me of a young people's service that we set up in our sexual health and HIV clinic in London more years ago now than I care to remember. And I think about the challenges that we faced in setting this service up, and these are challenges that I believe are the same everywhere. Our clinic was located in a part of London with many schools, and at the time we set the clinic up, London had the highest teenage pregnancy rate in Europe. I'm happy to say that this is no longer the case, but it was I think great shame for all of us who work in sexual health. And because our rates of teenage pregnancy were so high, the government created a teenage pregnancy strategy to address this. And this included improving access to sexual health services. Despite the fact that we were surrounded by many young people who went to school in the local area, we noticed that very few of them accessed our services. And we only held a young people's clinic one day a week, and on that one day, hardly anybody came. And so we were really interested to understand why there were so many young people around, but they didn't come to our clinic. And so to cut a very long story short, we delivered a questionnaire to 746 young people in local schools, and we had a 100% response rate. And they told us about the kind of clinic that they would like to attend and the kind of clinic that they would not want to attend. And they also reported that they were being turned away from our clinic on the one day of the week that we held a young person's clinic, and they were very unhappy about this. Many of the things that they told us were not a surprise. They told us that they wanted clinic staff to be supportive and non-judgmental. They wanted what they told staff to be confidential. And in particular, they said that they did not want staff to tell their parents that they had come to the clinic. Girls, more so than boys, wanted to attend with their friends. Boys didn't really care whether they came on their own, but girls really wanted to come together. But girls also wanted to be able to speak to staff about issues such as contraception. And I think this is really important because many parents are reluctant to or don't really know how to speak to their children about sex. And the clinic was one place where girls felt that they could come and ask questions and be given reliable and truthful advice. But there were also, we were also surprised by some things. So we felt that teenagers would perhaps not want to share a waiting room with adults because we ran a service for a large number of people of different ages. And we were surprised to see that older young people in particular didn't mind sharing a waiting room with adults as long as it wasn't their parents. They were also happy to see staff of different ages. And we thought that they would want to see younger members of staff. But issues about confidentiality and keeping and being non-judgmental were the most important things to these young people. But they were also very clear that the clinic needed to be open more than one day a week, and ideally, if possible, on a Saturday. And so we listened, and we created what became one of the most successful young people's services in London. And this was not because we had any financial investment in the clinic. We did nothing new. We didn't create anything new. We used the resources that we had. But it was successful because young people felt listened to, and they told their friends, and their friends told their friends, because word of mouth is extremely powerful for young people. And we published this work in the journal Sexually Transmitted Infections, and it was in 2002, so it was a long time ago. But actually, in looking at the literature and reading Lauren's slides that she's going to present in this symposium today, the issues remain the same. And so if people are interested in seeing the questionnaire, you can find the questionnaire in STI Journal under my name, and you can perhaps replicate a similar questionnaire for young people who attend your service. So why am I telling you this? We've heard throughout this conference about the high rates of HIV, of new HIV infections in young women in particular, but we also know that people of trans experience have far higher rates of HIV acquisition than in the general population. In our advisory board last year, we heard from young people that their experiences of healthcare were often not what they hoped they would be, and many described experiences that made them reluctant to return to the clinic. But they also acknowledged that healthcare providers, and nurses in particular, were overburdened, and that this often resulted in them being treated unsympathetically. But what we heard from young people overwhelmingly is that they felt that it would be of great benefit if service users and service providers could come together to discuss their challenges and try to solve them together. And the way to do this will be different from one clinic to another and from one country to another. But I believe that if we truly mean to end HIV in these incredible people who are our future, that we must be their allies. And so I'm handing you over to my sisters Sibulele, Lauren, and Sunflower, so that they can share their thoughts with you. Thank you very much.
Thank you very much, Dr. Nneka. My name is Sibulele Sibaca Nomnganga, and I'm from Johannesburg in South Africa. At the age of 16, I lost my dad to AIDS. My mom had died a couple of years earlier, and my father became the one who looked after my brother and I. And so when he died, my brother and I immediately became a child-headed household. I remember when my dad died, it was a really confusing time in my life, wondering what I'd done wrong. I had a lot of questions and no answers. And in my community, I just kept being told I was too young to understand. I knew that I needed the questions to be answered. I knew something was wrong. I was being stigmatized. I lost a lot of friends. I lost a lot of family members. And I was just unclear about what was going on in my life. And I knew that perhaps going to the local clinic would help me, but I was just so scared. I wasn't scared of them telling my parents, obviously, but I was just scared of how much more stigmatized I would be. But I remember walking into the clinic, and I remember that day very clearly. It's as though she could read my heart and how heavy it was, and how I had absolutely no one I could trust to talk to. The first thing I said to her, the healthcare provider, was, "Am I going to die?" And I remember her saying, "Do you want to die?" And I said, "No." She says, "Then don't. Don't die. Live. And I'm here to help you live." She gave me an option, and I ran with it. She continuously, consistently gave me information, even when I didn't ask for it. When she saw me in the streets, she didn't pretend like we knew each other from the clinic. She just walked by, like she didn't even know me. Because she knew that the things that I was telling her and the things that I was going through were between her and I. Now, I know that this is not the typical story of what other young people experience when they go to the clinic. I know that. But that nurse saved my life and inspired the journey that I took on in my life after that. Because I knew that there were so many young women and girls who were not going to the clinic, who were supposed to be going to the clinic, to be accessing healthcare, getting information, getting contraceptives, getting ARVs, and they were not, because they were just too afraid of what the community would say. And so that inspired the journey that I went on to ensure to build a community where girls and young women were not afraid to go to the clinic and ask questions, even demand the service that they knew was their right. While many things have been great in girls and young women accessing healthcare, we still have a very long way to go. Where not all healthcare providers know what to say. It's not that they're not kind. It's not that they don't want to give us the attention. Sometimes the long lines and queues can be really, really hard. But sometimes we just want somebody to say, "I'm going to hold your hand through this, and we're going to get to the other side together." Not today, not in one go, but over a period of time. And I'm so grateful to that nurse, because that nurse inspired me starting my own organization, where I work with over 700 girls and young women in South Africa today. And we work with local clinics to ensure that they are youth-friendly, they're accessible, and that they not just become places to access healthcare, but to access life. And that for us is very key as an organization. And so today, really, my parting words would be, while you've got the science in your hands, and you've got the opportunity for us to not become statistics, you also have the opportunity to give us life and help us choose the life that we want to have and help us be the best versions while living out that life. So I really want you to know that you hold that in your hands. We trust you. We know that you've got the information. And if you told us we're going to live, and we're going to live great lives, we will believe you. Thank you.
Morning to all of you, and thank you to ViiV for inviting me to be part of this incredible panel. As was mentioned earlier, I am a clinician with the Desmond Tutu Health Foundation in Cape Town, where I work with young people living with HIV in a community-based research clinic. And today my challenge is to provide the healthcare providers' perspective on this issue. We know that recent years have shown an increased interest in the health of adolescents and young people, and an acknowledgement of the challenges that they face and the requirements that they have of the health system and healthcare providers. We also know, and have heard today, and will hear, that despite the knowledge gained in this area, many young people's needs are still not being met by our current systems. So today I hope to emphasize that although robust health systems changes may not be within our sphere of influence as individual healthcare providers, we can still have a tremendous impact on the health of the young people who are in our care. So what is the challenge that we face when caring for young people? Adolescence is ultimately a time of tremendous change. Young people have emerging autonomy and over their lives, but still have limited resources with which they can act. They have an increase in the quantity and variety of social interactions, and this can increase their vulnerabilities. They're also in the midst of developing their self-identity, sexual identity, and gender identity. And they have evolving cognitive abilities as well as greater impulsivity. In short, they are facing a transition from childhood to adulthood, which can be tumultuous or it can be smooth, but whichever way it goes, it's going to have a huge impact on the rest of their lives and their health. So how in particular does this influence young people living with HIV? Well, the first thing is the issues with stigma. Stigma can be real or perceived. It can be internal or external from school friends, peers, families, and importantly, healthcare providers. There are also issues with disclosure. We often see in the clinics that we work in young adolescents who were perinatally infected who are still not aware of their status, and being disclosed to quite late in life and quite suddenly can have a huge impact on their acceptance of their status. And then there's also disclosure at school and within social groups. They also have increased mental health needs and may struggle with coping with a chronic condition, balancing academics and health needs, and a range of psychosocial issues, whether this is lack of familial support, orphanhood, violence, or food insecurity. So why is it important to get this right? Well, we know that young people are at greater risk of non-adherence, and we also know that young people have lower rates of viral suppression compared to adults. And the consequences of this can be an increased HIV morbidity and mortality, increased risk of antiretroviral resistance, and an increased risk of onward transmission of HIV. So what can we do? The WHO provides a framework for quality of care that states that health services need to be equitable, accessible, acceptable, appropriate, and effective. So essentially, the goal is that all adolescents are able and are willing to access the right services provided in the right way. And there's plenty of guidance available on how to set up adolescent and youth-friendly services. But systems are slow to change. And as I've said before, not all of us will be in the position to change the systems in which we work. So what impacts can we as individual healthcare providers have on the health of young people living with HIV? And to answer that, we need to first understand what it is that young people want from us. And the best way to find that out is to ask them. Adolescents are a heterogeneous group. They have a range of different expectations and preferences when it comes to their healthcare. And these can vary greatly by age, region, and health condition. So we need to use differentiated care models, which place our young people living with HIV at the center. And now I would like to run through the when, where, who, and what of our health systems. So when is care provided? So as healthcare providers, we need to understand the difficult decisions that go into balancing academic needs and health needs. This has been referred to as the student's paradox. So in typical systems of care, prioritizing your health needs means missing out on school teaching time, maybe examinations, assessments. Prioritizing your academic needs means missing clinic appointments and medication collections. And we see this all the time in the clinics that we work in, that young people have been labeled as non-adherent. And when you actually dig into the reasons for that, it's that they were prioritizing exams and other schoolwork. So we all understand that there are recommendations for later clinic times and opening on weekends. However, we may not have control over when our clinic opens. So is there a way that we can fast track young people who are students through the clinic so that they miss less school time? Can we show flexibility around important events, such as exams that conflict with their appointments? And this could be as simple as having easy mechanisms for them to contact us and change their appointments, and for us to provide them with sufficient bridging doses to cover that time. Can we also reduce the need for multiple appointments by integrating their HIV care with other services provided at the clinic? We often see in the clinics that we work in that patients are given one date for their HIV medication, another date for their family planning, and another date for their pap smear. And it's just impossible when you are in any situation, but especially when you're attending school. Where is care provided? It has been consistently shown that young people do prefer their own clinic space, and they sometimes find it challenging and stigmatizing to be around the general adult population. Again, resources may constrain our abilities to do this in our setting, but we can try to reduce the frequency of visits and decrease waiting times. In addition, we can consider alternative modes of care delivery, for example, mobile clinics, and we can do things like down-refer stable patients into peer support adherence clubs that may meet outside the clinic setting. Who is providing the care? So research has shown that adolescents want providers who understand and respond to adolescent health needs and development needs, and who are supportive and non-judgmental. They also appreciate consistency and the ability to develop long-term relationships with staff and respond well to being told the facts of their disease and treatment in an honest and straightforward way. It may not be possible in our settings for there to be staff who are full-time dedicated to the care of adolescents, but it's important that there is an awareness of the challenges that young people face, that there are robust referral pathways in place, and that staff are aware of the laws surrounding minors and healthcare. It has also been shown in a study in the Eastern Cape in South Africa that there were 5 main criteria of care that were associated with an increased retention of adolescents in HIV care, and these were called the STACK criteria. And there's just 2 that I want to highlight here. So firstly, staff who have enough time for adolescents, and secondly, staff who are perceived to be kind to adolescents. Both of these were associated with a greater than 2.5 times the odds of retention in care. And I know time can especially be a challenging thing when we've got a long queue of patients to be seen in our clinics. But I think Sibu also spoke to that. It's not that you have to fix everything in that appointment. It's just the knowledge that you can, maintain that relationship with the adolescent and perhaps address the issue at the next visit and have a plan in place that will reassure them that you have heard them and that you do care. Finally, what care is being provided? As I mentioned earlier, it is vital to integrate HIV care with the other needs of young people. So referral pathways need to be robust and include social and mental health services. And as we look to the future with the development and rollout of long-acting injectable antiretrovirals, we need to empower ourselves to have the knowledge to be able to counsel young people on the choice of the mode of ART delivery. So I'd like to conclude my presentation with a call to action. We as healthcare providers can do better when it comes to young people living with HIV in our care. Let us go and be the champions in our facilities who advocate for young people. Let us commit to working together with young people to make the changes that we can within our resource-constrained settings. And together, let us be advocates for change with policymakers to ensure our young people get the care that they deserve. And finally, I would like to share a quote from my organization's late patron, Desmond Tutu, which I think speaks to what I've been talking about today. Do your little bit of good where you are. It is those little bits of good put together that overwhelm the world. Thank you.
They set me up, they put me after a doctor. So now I have to compete, but I will not compete. As she was speaking, one funny thing went through my mind. That quote that has been very popular nowadays that says, you like someone until they open their mouth. Because the funny thing is that it has actually happened to me. I once met this very funny person on Tinder. And we moved to a call, and this person then says, he hears my voice and he goes, that's a man. And he blocks me. So now I'm thinking that, oh wait, this is going to happen again when I start speaking and people are like, wait a minute, what is this person saying? So for those who are praying for me, please wake up. My name is Sunflower and I'm a trans woman from Zimbabwe. And I'm here to share my experience to say I am not a statistic. I am a person living with HIV, or HIV is living with me, as my friend from the 8th board would say. So who am I? I think that's a very interesting question, because in these conversations and even in broader conversations around LGBTQI persons, you realize that there is this conversation, but as an LGBTQI person, you're not identifying yourself with the conversation, because either the two extremes are trying to represent you as something that you're not. So who am I? I'm a law student. I wish I was a girlfriend, but I'm not. I'm a daughter. I'm a friend. And I think all those important aspects of my life should be considered when I go to access healthcare services. I think the one part of me that is always considered is that I'm a trans woman. But that doesn't factor into account other aspects of my life, which is I'm a student. And as she was saying in her presentation, it can affect when I go to access my healthcare services. It affects the time that I want to spend at the clinic. But it also affects the kind of service that I expect to receive from the clinic. Because if I go to the healthcare worker and they say, oh, that one, and they are providing services for a trans woman, they might not know that I'm also a drug user, because, well, life is hard. And as a trans woman, it's even harder. And I regularly might need to inject something. And if that aspect is not taken into account, this person might not really fully cater into all the experiences I need. And also coming from a country where there is no access to hormone replacement therapy, most trans people self-inject. So if my sister has HRT from a friend who lives in South Africa, then she will share with her sisters. We're using the same needle. So those are certain aspects that are not taken into account if the healthcare provider is only seeing a trans woman and not really taking into account all those other aspects. And this is not even taking into account that most trans people are chased out of homes when they come out or when they are outed, and most turn into sex work. So you are thinking that I'm a trans woman, but I have one sexual partner, but I have multiple sexual partners. So all those aspects need to be taken into account. And if you're going to be only seeing a trans woman in front of you, you will not cater for all those healthcare needs. And the service that I'm going to get is not only not going to be great to me, but I'm going to go out and tell my sisters that that healthcare facility is mission abort, and they're not going to come. So, and those are certain aspects that we really need to take into account. And I think it's very important that within even the broader conversation around stigma and discrimination, because I remember at one point I did go, and the intersectionality between being trans and being a young person, I did go to a healthcare facility, and it's easy, usually from my country, it's easier to just say, oh, I'm a gay man. Then they're like, oh, okay. I was sensitized at some conference about you people. No, it's okay. So I go to the healthcare facility, and then she gets to a point where she asks my age, and I go, I'm 19, I was 19 at the time, and she's like, wait a minute, my son is also 19. And then she goes on and starts wanting to pray for me and convert me into the church. And that one experience can sour the healthcare experience for a young person. And you know what I'm going to do? When I go out, I'm going to tell my trans sisters, that healthcare facility is mission abort. And then you ask, and then now when programmers come, they say, oh, hard to reach populations. We're not hard to reach. We're very easy to reach. You chased us out of your facilities, you chased us out of your institutions, and then you called us hard to reach. And that's very concerning to me, because then you say, oh, we intentionally hide HIV services, run, you're a trans person. But that's not what happens. We need those services, but the experiences that we get from the healthcare facility determine whether we come back, we recommend other people to come, or we decide just to stay away. And it's also, I think, healthcare providers sometimes feel that we're asking for too much, but if you're an LGBTQI person or a trans person, you don't just face stigma and discrimination in the healthcare facility. You face stigma and discrimination everywhere that you go. For example, usually when I'm at school, I can't walk alone because I'm afraid that, you know, there's someone with their own ideas of who I'm supposed to be, and I'm not sticking to those ideas, and they might turn violent. So I always have to walk with a friend or something like that. And at home, it's another different situation. Most LGBTQI persons, young persons, come from families that are not accepting. And even just walking, because I remember when I was at OR Tambo Airport and I wanted to use the bathroom, and they have security at the bathrooms, and I'm like, oh, yeah, that situation again. So I tried to use the men's bathroom, and this woman who's the security looks at me and she's like, why are you going in there? And these are experiences that you encounter before you get to the healthcare facility. And the healthcare provider is then the icing on the cake of stigma and discrimination. So I think it's very important to be kind, to be empathetic, to be sympathetic, and to try and understand and give non-judgmental healthcare services, because it determines the life or death of a young trans person or a young LGBTQI person. And sometimes maybe the only friend, I'm glad, as my sister said earlier, the only friend that you might get is the healthcare provider. And if the healthcare provider rejects you, then it's another icing on the cake. But finally, what I really want to share maybe is what do young people want, especially young LGBTQI persons? I think a good example I always use is that if I were a trans man and I was dating another man, I would have to take my hormones, I would have to take, if I'm also living with HIV, I would have to take ARVs, and I also have to take contraception. That's a lot of medication. That's a lot of medication on one person. And I am challenging you as scientists, as innovators, to say, let's start thinking, even in our research and innovation, let's start thinking about LGBTQI persons, because you know what most trans people would do? Do away with your art, do away with your contraception. We will abort the child if we get there, but I'm going to take my hormones. And because hormone replacement therapy is life or death for most of us. And the one biggest gap that has existed in HIV interventions and HIV research and innovation is only to cater for HIV as if HIV exists as a single entity. But there are all these other aspects that increase your vulnerability. And as long as those other aspects are not addressed, art is just one thing that is there. And it might not really be the life-saving medication that young trans and LGBTQI persons want. And please speak to us, please. We're not hard to reach, we're there. And sometimes the reason why most programming fails, especially when it tries to address key populations in Africa or LGBTQI persons in Africa, is that there's no LGBTQI person sitting on the board, there's no LGBTQI person sitting when there's programming, there's no LGBTQI person even within your structures and institutions and boards. And then you try to design a program for LGBTQI persons from Africa. It's definitely going to fail because it's not addressing the local needs of the local community. We know what works for us. We have been working on it. We're working with young people. We're working with young LGBTQI persons. And we know what works. We know what doesn't work. But you will never know that until you come and consult us. And not just a consultation of, oh, it's a conference, give them 10 minutes, give them sweets and $50 and they go home. No, it takes listening to young people, taking what young people are recommending to you seriously and implementing, and not just engaging young people as beneficiaries, but as partners and collaborators in the whole process. And I think that is what is going to help us end HIV and AIDS in Africa. Thank you for your time.
Wow, thank you to our speakers. What we're going to have now is an open Q&A session. And it is an engaging Q&A session. So whilst we're calling it a Q&A session, please share a comment, please have an input, please share your experiences. This platform is one way we want to hear, and we want to hear. So I'm going to hand over to Nneka to please start our open session, and let's have a dialogue.
Thank you very much, Sib. And thank you to the three of you. I mean, I don't know, what can you say? Yeah, it was so moving to hear what Sibulele and Sunflower had to tell us, and I think it's really important that we hear them. And also Lauren just showing the data. And you know, although we want this to be a conversation, it's a conversation that is backed by science and research and data that demonstrates really clearly that if you involve young people in the development of services, as is the case for all people who use services, if we involve the people who are using services in the development of those services, then we stand to be much more successful in our delivery of those services than we would if we do it on our own. So please think about questions that you would like to ask the panel, and I think that there are people around with roving mics. But I'm going to start by just asking a question to everybody here on this panel about a group of people who we haven't really talked about, and that is young men. And we know that the highest rates of HIV infection, of new infections, are in young women. But young women acquire HIV from men, usually older men, but older men start out as young men. And young men and young women may infect each other. And so I think that as we are having conversations about access of young women to services, access of people of trans experience to services, I think we do have to include men in these conversations. And there has been a lot of discussion about this in previous sessions. And so first I'm going to ask Lauren. Lauren, what are your thoughts about how we might encourage young men into this conversation? And I know that there may not be a right answer or a wrong answer, but I'd be really interested in your thoughts.
Thank you. So I think that this is a big challenge, and as you said, is somewhat of a forgotten group because we do focus mainly on adolescent girls and young women and other key populations. But I can say from my personal experience that in the clinic, the young men that we see are mainly those who have been perinatally infected, who have sort of grown up in the healthcare system. We don't see a lot of newly infected young men, even though they are out there. And so we definitely are not reaching them as a population. And I think it just needs to go back to, we need to consult with them. We need to find them and ask them, what is it that they want from us? What is it that they don't like about our current clinic systems, and how can we engage them in the care? And that might be using alternative methods like mobile clinics, specific men's clinics, but it really does require more engagement, I think.
Thank you. Sibu? Yeah, I will.
So in our experience, we have a program called Boys Will Be Boys, and initially the program started as a GBV prevention program, which was really successful just in understanding, you know, how boys and young men find themselves in those situations, you know, be it background, upbringing, and the like. But what we found more and more is that they had a lot of health-related questions, which at the time, as a young women-led organization, we didn't have the answers to. And this required us to acknowledge that and then start recruiting people who are going to help us with those questions to be able to address them. And we found more and more boys and young men in our program wanting to go to the clinic, but feeling so out of place when they do go there, because they have no reference of any other older men in their lives who've gone before. So we found ourselves having to deal with, while it was a beautiful problem that we had, that they were wanting the information, it almost felt like we were dropping them, because we didn't have the tools, even sometimes the resources, to complete the bridge for them. What we do know for sure, though, is that we do need to engage them. They want to be engaged. They want to be part of the solution. A lot of them are just saying, I don't want to be the problem, you know, and so help me to help you.
Thank you. And before we go to microphone 4, I'm just going to ask Sunflower whether you have any additional comments.
I think one thing that I would add is just that maybe it's also encouraging behavior change. And I don't know, maybe this is through amplifying young boys and young men who actually do go to get services. Because I think with men is that the duty of healthcare has always been placed on the woman, the mother, or the girl child. Even from childhood, the person was always concerned about your healthcare was your mother. If you had to go to the clinic or you had medication, it was always the mother. So the point of reference in the home was the father, was not actively pursuing his healthcare, and then they have their friends and then the whole circle. So I think representation and amplifying voices of those who do go to access those healthcare services might be one of the ways that we need to do to encourage. And also I think maybe out of the ambit of this conversation is also the issue of age of consent laws, especially in Africa, that mostly prohibit young men from go and access services without the consent of their parents. Because the first thing that then becomes is, are you now engaging in sex? And you know, when that conversation happens in an African home, there's a belt and a Bible also involved. So I think it's also very important to also take that into consideration.
Thank you very much to the three of you. Microphone 4.
Thanks, Nneka, and I just really want to congratulate fantastic panel and so inspiring. Thanks to all of you for sharing personal journeys. I really appreciate that. So my question goes a little bit more to the, thanks Lauren for a very pragmatic kind of what can we be doing. But I do want you to comment, if you maybe also, you know, Spoo and Sunflower could as well. What about training for healthcare providers? I think, you know, we launched them. I think that comment, Sunflower, that nursemaid comes from a place of being a mother and not necessarily being a trained nurse, to know that it's not okay to, you know, to launch into, you know, very much promoting your own emotional feelings about this. So what about training for healthcare providers? Are we doing enough? Can we be doing more? And going one step further, Lauren, coaching healthcare providers. You know, I think there's a lot of burnout. There's a lot of self-care that's not happening. So we're not doing what we should be doing, partly because we're overworked and, you know, underpaid a lot of the time, and things are tough. So I just wondered if you could talk a little bit more about that side of the desk, if you like.
Sure. I think that is a huge gap, the training. If I look at the clinics where we work, one of the big issues is the huge turnover of staff. So you might do the training and then suddenly you find yourself with a completely different set of people working in the environment. So it needs to be consistent and it needs to be pervasive in all cadres of staff. And I think Sunflower also mentioned, you know, when she goes to the clinic, it's from the front gate. You know, it's from the security guard, it's from the person at reception getting your folder, that everyone needs to be trained in these aspects of adolescent care and LGBTQI care. So I've noticed in the clinics currently that it's a gap, and I think that is something that we definitely need to address on a more systemic way. I don't know if you want to.
And I'd just like to add on that, on the continuous coaching that you're talking about, because so much changes every day. It's new language. You're also wanting to make sure that the healthcare provider is not being offensive in any way, and not because they want to be, but because what they knew is old news, you know. And so the continuous coaching is really important, and also the space to allow us to teach them. When we come into the room, we are looking for the help, right? We are looking for the medical attention. But for the space to be conducive for them to go, oh, I didn't know that. What do you mean? And for it to be okay, and not them feeling like they didn't know, but they just really didn't. And this is new, and did they know that we are now smoking our ARV drugs? I mean, and this is the new thing to make me happy. And maybe they didn't know that, and it's time for me to teach them that. So I think it's the continuous coaching, the once-off training, absolutely important. But the continuous coaching, conversation, chilled vibes, also not like this is a training now, but like very chilled vibes, let me teach you something you didn't know.
I think for me, I'll just say two things particularly, because also I think that's what we've experienced in Zimbabwe, the high turnover. So nurses are leaving the country in droves. So 1 minute you train, you come the next 3 months, it's a completely new staff. And what we've been advocating for as young people is that maybe it's time to incorporate it into the curriculum. Maybe it's time that the nursing curriculum emphasizes on human rights-centered, youth-friendly approaches from the curriculum, from nursing school, so that when they go, they know within the health charter that this is what I was taught, this is what I was expected. Then the second thing, it's also what I was talking about in terms of collaborating with young people. Let young people be your friends within your healthcare facilities. Invite one young person to sit in your board. You don't have to pay them. If you know that they have an interest in healthcare, let them be consistently there at the hospital when the hospital is making regulations, policies. Those are the kind of partnerships that we want as young people, not these dressing on the table kind of interactions, but meaningful and intentional interactions. Those are the ways that we can address these gaps within the healthcare facilities.
Thank you very much.
Nneka, I'd just like to ask a question.
There's a question just over there.
Oh, we've got a question, great.
The panelists, I mean, I think why people are we're reflecting a lot, just to let you know, you've really raised a lot of issues. Speaking for myself, have been very ignorant. Sunshine, when you say it's easier to say you're a gay man, I get it. Because this whole spectrum of trans and what have you, I just didn't know about it. So I guess you need to forgive us because we are ignorant. My question is, and both of you have started youth organizations, is how can we do better in supporting your organizations? Is there anything that you need from us so that not to take over your organizations? Yes, you can come on our boards, but is there anything we can do to better support your organizations?
Thank you very much for that question. Collaboration is key for us. Partnerships that matter, and I think Sunflower mentioned the meaningful and intentional engagement of the things that we have to say. So for us, it's really easy to have a conversation and a program around comprehensive sexuality education, but it's even better if we're able to say, do you know the doctor and the nurse at the local clinic? Please ask for Sarah. Sarah is waiting to receive you as a member of this organization. So for us, it brings integrity to our program, and it says that we are partners in their healthcare, and that no matter what happens and what treatment they get from a Sarah who's not available on the day, they'll come back to us, but they know that Sarah is their friend. Not only that, but Sarah to leave the clinic and come to our environment and meet Sarah in that environment, so that they know that they can have access to Sarah when they like. And I think Lauren mentioned about having various ways of communicating, maybe a WhatsApp group that can be created, because that's one of the things because we get asked a lot of questions by young people, girls and young women, adolescent boys and young men, that we are unable to answer because they're so technical. And it'll be so cool for us if we had conversation with a clinician and we're able to talk to you over WhatsApp, send you a voice note, there's this current issue happening, can you respond when you can? You send a voice note back. It's so personal. I play the voice note for the young person, they feel like that you were they feel like they've just consulted with you. So that's some of the ways that I think would really be meaningful for us, for you to get involved. And I think lastly is just the attitude of wanting to be a part of the work that we do, right? Because I think a lot of the time it's easy to just say, well, we're here, talk to us when you need us. But it's another to really, really mean that. And that when we do reach out, we know that we've got you as a partner.
I think just to add on, I think particularly we have the innovation, we have the young people, but we do not have the experience. So most of these established organizations have so much experience because they've been in the HIV space for a very long time. And what I've found sometimes within is that as a young person, you are treated as a threat when it's not even a competition. We're just helping each other to end HIV and AIDS. So I think the one way which will be very important for me for collaboration with youth organization is to share your experience. We have the innovation, but you can say, okay, this is what we've done, and you can innovate from there with the information of what we've done. Also promote access. Most of the established organizations have access not just to regional, national, and internet, and even international spaces. So when you do get to that space and you have a chance to invite an organization, be intentional about it. Invite a youth organization. If you're in a space and you have an opportunity to recommend an organization, recommend the youth organizations. Those are meaningful ways that you can involve and engage with youth organizations. And finally, sometimes within the grant-making process, you find out that they'll say, oh, we want an organization with 10, 30 years of experience. And as a youth organization, most of the times, we're underfunded and we do not have the experience. So write letters to vouch for us. Say you're going to be the grant holder for us. In case we need money, we get it from you. Those are things that I think are very important in terms of collaborating with youth organizations.
Thank you very much to both of you. Microphone 3.
Yeah, thank you very much. My name is Nwokolo. Just to comment, the first one is about the role of the government. If we're talking about healthcare workers, talking about healthcare facilities, in most of our countries, a lot of those facilities are government-run facilities. So we need the government to sit at the table to have a better understanding of some of the issues we're talking about. Because at the end of the day, you have healthcare workers who have been trained, who are motivated, who are willing to make the necessary changes, but because of the settings where they work, they're incapacitated. So I think government has a major role to play in this. The second thing that I would like to raise is about the need to expand or to extend the definition of healthcare workers, and I'm happy, I think somebody already alluded to that, beyond just traditional clinicians and nurses, and make sure that when we're talking about sensitization and training, we expand this to all individuals who are working within the facilities, because to a great extent, they determine how much stigma and discrimination individuals who walk into the facilities receive, because it could start from the gate, from the cleaner, from the record person. By the time the client gets to the nurse or the doctor, he or she has already made it, I'm no longer coming to this facility. So I think that is important. The last point is, and I think this is a very interesting perspective, that sometimes healthcare workers know what to do, but they also suffer stigmatization from other healthcare workers. You walk into a facility, you have a patient or a client who's waiting to see a nurse, and then your colleagues are telling you, oh, your people are here. So sometimes the healthcare providers want to do the right thing, but they are also stigmatized by their co-workers. So I think we need to do a lot of work in that mentoring aspect so that even individuals within the facilities who are willing to work and provide the right services are encouraged and they're motivated to do the right thing. Thank you.
Do any of you want to make a comment about that? Or no, I think that was very well said, and I think, yeah, it's so true. Any other comments, questions from the floor? Yes?
Thank you all for your contributions, very, very helpful. I'm Nadia Samagudu from Institute of Human Virology, Nigeria. What I wanted to say was that one of the things I find, I'm a pediatrician, so one of the things I find in working with young people is, and many healthcare facilities in Nigeria, is that often in this clinic, there's that one healthcare worker who is very friendly, very youth responsive, and like loved by all the youth. And one of my jobs as a program implementer is to make sure that that person is retained in that space. Because once they are transferred, it almost collapses the program there. You have those healthcare workers who are so loved and do their work, but sometimes that is not taken into consideration, especially at public health facilities where nurses and doctors can be transferred anyhow. And so one of the things we need to consider is that while we are trying to have healthcare workers be more universally youth responsive, adolescent responsive, the few healthcare workers who get it, who are loved by those adolescents, that we do our best to retain them. And so I'm really working on doing that, and I'm encouraging everybody to do those healthcare workers. Once you remove them, you almost collapse the program at that facility. So thank you very much.
We have 1 minute left, I'm told. Well, what can I say? I think one thing that I'd really like to say before I close is thank you to all the ViiV support for Africa for what we're doing here. And one of the key aspects that was mentioned in the advisory board that Nneka had spoken about was about mental health, especially in the young people. So another take-home message, as you look after young people living with HIV, please make sure that you integrate mental health in taking care of them. But from a ViiV perspective, this is definitely one of many. But it's one of many where ViiV cannot do it on our own. And it's one of many where ViiV wants to hear more. And it's one of many where ViiV is committed to partnerships. So open discussions, please, if you come to the booth at any given point in time, we have got senior leadership here. Please make the time to come and talk to us about what was discussed here, what it is that you think we can do better, what partnerships can we consider, and making sure that this is not a once-off, but it's something that we're going to continue building on until we get it right. On behalf of ViiV and our beautiful panel of speakers and everyone attending, thank you.
Thank you.